With over 400 million people living with diabetes around the world, and that number growing rapidly, the challenges of management and prevention of diabetes are ever increasing. Now, diabetes experts from basic scientists to clinicians are coming together from across the globe to San Francisco, USA, to work to meet these challenges. Tech hub of the West Coast and gateway to the Pacific, this week, the city will play host to discussions on everything from islet biology to epidemiology, genetics to nutrition. Bringing you the very latest research, clinical trials results, and state-of-the-art technology, this is the American Diabetes Association's 79th Scientific Sessions, and we're ADA TV. Welcome back to the Moscone for our second show here at the American Diabetes Association's 79th Scientific Sessions. It's Friday and the meeting is really getting underway as delegates from all over the world begin to get to grips with the very latest in the field. And ADA TV is here to catch some of the very best it has to offer. Let's see what's on the show today.
There are many barriers to diabetes education. It's challenging. We are sitting inside of a hospital. We should be out in the community. We should be in health centers and senior centers, community centers and universities.
As educators, that's something that we're really passionate about, is making something that is realistic and achievable for you as a patient and making that sustainable. Otherwise, it's not going to last.
2 or 3 things: education, education and education. Patients should know the target values or what are their targets of their blood sugar level, their blood pressure levels, their cholesterol levels and their HbA1c level. They should know about it.
And now I'm here at the ADA studio and I am with ADA President for Healthcare and Education, Gretchen Yousef, and thank you so much for being here.
Thank you for inviting me.
And I know you're a diabetes educator and obviously so many sessions to take in this time around. What are you most looking forward to? What's on your list?
So there are just a lot of studies that are going to be presenting results, a lot of medication studies, and the outcomes of these studies may really have a positive impact on persons with diabetes. So I'm excited about hearing about that. The nutrition consensus paper was published this past spring, and they're actually going to be interviewing the authors and talking about healthy dietary patterns and what's best for people with diabetes. And I think this is really important for most people who see patients, physicians, anyone who works with patients to actually attend, because there's so many myths about diabetes, what people should eat, and this provides evidence-based guidelines.
What issues would you say are most important to you that you're focusing on as of late?
So my talk is actually on access to care. It's all about access, and it's really important that people have access to the medications that they need. It's been really challenging lately because insulin prices have more than tripled since 2002, and some people can't afford insulin. And people are dying because they can't afford insulin because they're rationing it. So that's one access point. The other access point that's near and dear to my heart is diabetes education. How can someone self-manage their disease if they don't know what to eat, if they don't know how to take their medication, how to take their insulin? And I see people in our practice that have had diabetes for 20 years with multiple complications that have never sat with a diabetes educator. And right now, the recommendations are that there's 4 critical times people see a diabetes educator, and we're lucky if people actually see them when they come in and have complications.
Why do you think that is?
Well, there are many barriers to diabetes education. It's challenging. We are sitting inside of a hospital. So location's one of the challenges. We should be out in the community. We should be in health centers and senior centers, community centers and universities. Also, the payment structure for Medicare is difficult. There is a bill in the House and Senate right now looking at these barriers, and hopefully it will go through and we'll have these policy change so it will make it easier for people to access.
Well, it sounds wonderful, and hopefully that will go through and forward. And I want to thank you, Gretchen Yousef, for your time.
Thank you.
Thank you. Nutrition has a major impact on the prevention and management of type 2 diabetes, and the key thing is giving information to physicians to help manage diabetes with their patients, and that's a major role with the ADA. And joining me now to talk about the guidelines in nutrition are two experts with the ADA, and thank you both for joining me. Let's first talk about how big a part of the type 2 diabetes treatment in nutrition is.
So nutrition is kind of a key component of managing diabetes because nutrition and what you eat impacts your blood sugar from meal to meal every day.
So how should physicians talk about nutrition to their patients? Obviously from the very start, I'm gathering, yes? Day one.
Absolutely. I think day one, food is the foundation really of who we are as people, right? Food is social, food is life-sustaining. Cultural, yeah. Food plays a major role in patients with diabetes, and as Sasha mentioned, so directly impacting blood glucose values, it's important to address that, I think, from day one.
Let's talk about the change in nutrition. We're talking about low carb, but that doesn't mean no carb necessarily. So why don't we talk about that?
Absolutely. A lot of what we hear when we hear low carb, a lot of people do think that means no carb. And there is a ketogenic diet that's a therapeutic kind of eating plan that's helped to treat epilepsy and different conditions. But for diabetes, the ADA just produced a consensus report with a group of experts, and what they found is the effective eating plans that are low carb are not as low as you'd think. They amount to somewhere around 26% of your calories from carbohydrates in a day, which is probably closer to 40-50 grams a day for a lot of people, which is really not what you think of as very low carb, and that was on the very low carb end.
Sounds like from what I'm hearing though, there's not one approach for everyone. It's a case-by-case basis, is that right?
Absolutely. What we're finding now is that really the diet that works best is the diet that's going to work best for you as an individual. So whether that be maybe a very low carb eating plan, or someone who maybe is a little bit more active, might need a little bit more carbohydrate, whatever's going to make them feel good, help sustain their weight loss goals, or maintain their weight and their blood glucose values, while keeping them in line with their cultural preferences and their, any food allergies or anything that they have.
Have you reached a consensus on this, on what is the best nutrition? Is there a complete consensus, or is it still out there, the discussions?
I think the discussions are out there in terms of people want a quick fix. It would be easier to say this is what everyone should do, I think. But the research is, when you look at research, it's sort of in ideal circumstances. And then when you go to implement that in real people living with lots of other things going on, other health conditions, socioeconomic status, just life gets in the way. And so when you're in a research study, you're following this diet very strictly for the most part. But then you get it onto life and it just doesn't always work.
You got to talk about sustainability,
yes.
right? So as educators, that's something that we're really passionate about, is making something that is realistic and achievable for you as a patient and making that sustainable. Otherwise, it's not going to last.
Let's talk about that bad topic, fad diets. How are you challenged with that? How do you explain that that's not the route to go? And obviously I wouldn't assume there is one that works.
Not necessarily. I mean, my approach though is when someone comes to me as a patient, I'm thinking if they're really motivated to do something, I'm going to find a way to make it work. Because people come and say, I want to do the ketogenic diet, or I want to come and do this or that, whatever the fad diet is. But then when you ask them, what does that mean to you? You get a very different picture, and usually we can balance out something that's very much more realistic and sustainable.
And when it comes down to it, we want the best results. So what is the impact on having good nutrition on type 2 diabetes? What are we seeing? Good nutrition equals a healthy outcome.
I think good nutrition equals a satisfied and a healthy individual, right? An individual who is getting all the nutrients they need, probably, hopefully, is at their weight goal, is at their blood glucose value goal. They find that it's achievable. They're not stressed out by food.
They're not planning several meals, during the day. I eat this and my family eats that. They can interact with family and be happy in their life as well.
Yeah, it's realistic for them, it's sustainable for them, and I think that is the mark of quality of life, and that's what we're looking for in the treatment of diabetes.
And that's the bottom line. how do you both feel about things now? Are you enlightened? Are you seeing positive effects?
I think we're constantly learning every day. That's something that I tell my patients. I learn from them just as much as I'm going to learn from the scientific papers that get published. Hopefully those are good representation of what we're seeing day to day in practice. And hopefully we can also learn from that evidence and help our patients in their daily lives. Yeah.
Well, it's a pleasure meeting you both and listening and talking with you here, and thank you for being at the conference, and thank you for taking the time.
Appreciate it.
Now it's time for one of the highlights of ADA TV as we take a look at some of the companies, centers, and hospitals playing a central role in helping people living with diabetes through basic research and clinical care. Let's see where we visited this year. First up, we head back to Wan Medicine and the second part of their four-part story, focused on developing a new kind of glucokinase activator. Wan are hoping to help patients in China and beyond.
Diabetes is a very complicated disease, so the current therapy all have some issues like a certain side effect and hypoglycemia. We're thinking by developing a new drug targeting on the GK will have the potential to change the whole paradigm of the diabetic treatment.
Over the last 25 years, since we identified glucokinase is a very important enzyme that controls the blood glucose level, the major pharmaceutical companies and biotech companies start to go rush. Everybody start to do glucokinase activator.
Wan Medicine is based in Shanghai. Though we're based in China now, we have the ambition to become the global player in the diabetic treatment. Previously, other companies also developed GKA, but they all failed. They all have their issues.
Any overtreatment using high concentrations of glucokinase activators, these are very, very potent agents, leads to glucolipotoxicity, to all kinds of problems. One of the good decisions of Hua was to do a dose dependency and find the minimal effective therapeutic dose rather than looking at quick effects. Dorzagliatin has an advantage of acting in a glucose-dependent manner. The molecule only binds and activates at safe glucose levels.
Dorzagliatin is the fourth generation of GKA. When our scientists designed the drug, they looked into other GKA's problem and avoided the issues associated with them.
We have taken the 5 glucokinase activators, all entered in phase 2 clinical trial. Different chemical structure result in different type of glucokinase activators.
Some GKA only work in liver, some works both in liver and pancreas. We have to find the right molecule working on the right organ at the right time, at the right level, and mimic the natural glucoregulation effect of GK by itself. The most important thing, the drug itself not taking over of the role of glucose as a sensor.
Our blood glucose is controlled by the blood glucose, by the controlling hormone, insulin, glucagon, GLP-1, right? Those what we call the PD markers. In order to do this relatively complex system, you have to developing a computer model. We actually be able to model how dorzagliatin is changing the enzyme kinetics of glucokinase in the healthy state or in the diabetic state, so that allow us to pick the right dose to helping design the clinical trials. The phase 2 study was initiated in September of 2015, and the result is stunning. Reduced high blood glucose level, no hypoglycemia, no GI side effect. At the same time, it's improved insulin sensitivity and improve the glucose sensitivity, which is the underlying cause of the disease.
By repairing the glucose sensitivity, the whole body utilization of glucose can be also enhanced. In phase 2 studies, the glucose disposition index increased significantly after 12-week treatment with dorzagliatin. Surprisingly, for the drug-naive patient, and this maintained even after stopped treatment over 1 week. And this strongly indicates dorzagliatin may have the potential of the disease modifying.
Because it's addressed the underlying cause of the type 2 diabetes, it's going to offer the help to the patients in China and then in the rest of the world. So this is what we're going to do, working together with the medical experts, physicians, and scientists around the globe.
Artificial intelligence is having an impact on all walks of life, no least in medicine. Harnessing the power of machine learning, let's take a look at Switch app, which aims to predict, prevent, and improve outcomes for patients with diabetes.
Diabetes has emerged as an epidemic in Western civilization.
Switch is a clinically validated AI-based platform that promotes health, improves clinical outcomes, and prevents chronic diseases. We are focusing on different areas of health: physical activity, weight management, diet and nutrition, in a combination with disease management elements like medication adherence, treatment protocols, and assessment. These together provide a comprehensive solution that helps patients throughout their journey to become healthier. Switch is acting as a personal digital coach. By that, reduces the risk of diabetes. Johns Hopkins Endocrinology, Diabetes and Metabolic Division conducted a clinical trial using Switch, and we were able to show clinical meaningful outcomes in all measured evaluated. Increase in physical activity, weight reduction, and A1C reduction.
We thought about ways that we might be able to work with our employees to actually prevent illness from occurring at some point in the future. We realized that we're dealing with a group of people who are extremely busy. They have demanding jobs. Most of them have families. And so we had to come up with solutions that were time effective as well as effective in preventing diabetes.
The features that I use the most in Switch are the activity tracking, which is super easy. I can just tuck my phone in my pocket and it tracks how much I walk and run and how much activity that I get. I also use the nutrition tracking to track my meals.
Switch developed a behavioral change AI engine that takes into consideration different behavioral change science approaches and gamification and social reinforcements, all to make sure that people adhere and engage to the platform. The way that it works is by collecting data from the mobile device seamlessly, together with connected devices and patient-reported outcomes. All this data is being sent to our behavioral change platform that crunch it and come up with the right recommendation at the right time to the individual which is using the platform to make sure they adhere to the recommendation that is being sent to him.
Since I've been using Sweech, I've been able to be more active for longer periods of time without fatiguing as much, which means I get to play with my kids a lot longer and not have to sit down for breaks and hear, "Mommy, Mommy, no, let's go, let's play." I'm also able to see what and where I need to change my nutrition. So if I need to add a fruit here or a veggie there or cut back on a portion size, I'm able to do that a little more easily. And I actually just did a repeat blood work through my work, and it showed that my A1C is starting to drop.
I use the weight and the tracking of meals, which gives me an idea of what I'm eating and what I shouldn't be eating. I'm pretty much monitoring that a whole lot. And I'm finding out that a lot of stuff that I was eating is not really good for me. I'm more mindful of what I'm putting in my body. It's helping me and teaching me how to eat the right things and not just eat what I want all the time, because you have to be careful. Sweech app has made me accountable. I think the app is adapting to me, and I say that because I really, really appreciate the reminders that it'll give me. I may forget to record my dinner, and it'll remind me.
Among the 40% or so of our employees who had abnormal hemoglobin A1Cs or fasting blood sugars, there might be different risks associated with individuals in that class.
Sweech includes another layer that calculates the risk of developing chronic diseases based on historical medical and clinical information which is gathered from the health provider or from the patient itself. And for each individual, we are able to calculate his individual risk to develop chronic diseases within a time horizon of choice. This is important for the health provider to know how to allocate their resources. For the patient as another motivation tool to trigger them to adhere to a healthier lifestyle.
Mobile apps have the potential for impacting each of our lives in a manner that will be more time effective for us as we try to deal with competing demands on our time.
Creating a sustainable behavioral change and helping people adopt to a healthier lifestyle is not easy. I believe that what we are aiming for and the way that we are doing, which is unique, is something that will create the effect and will touch hundreds of millions of people around the globe, helping them live healthier.
Now to New Jersey, where China's Gann Lee Pharmaceuticals have established a world-class team to bring their affordable insulin biosimilars to the Western world. We stopped by to hear what motivates them and what the future holds.
We love what we do, and we love that it's going to benefit and potentially improve the lives of diabetes patients around the world.
With the focus in the United States on the cost of therapy for diabetic patients, we're really addressing that here at Gann Lee.
At Gann Lee, we all have a connection to somebody who suffers from this disease, and we're all striving to make their lives better.
My father has diabetes, and a dear friend's daughter was born with diabetes. I thought, what a great way for me to put my skill sets to a use that I can actually help people that are close to me.
Gann Lee was founded in 1998 in Beijing as a biotech company specializing in recombinant insulin analogs. And all of these products have been very popular therapeutic options for diabetics in China because they were a high-quality product offered at a reasonable price.
Here at Gann Lee, we are dedicated to develop high-quality medications by using high-quality standards, by interacting with the agencies and making sure that our products do meet the expectations of the agencies and the various country requirements.
More than 100 million US adults are now suffering from diabetes or are pre-diabetic, and the cost of the insulin required to treat this disease is skyrocketing.
Despite the many therapeutics that are available for treating diabetes, there's a significant number of patients that do not have access to the right medicines or are not adequately controlled. Gann Lee's focus is to improve the quality of patients' lives by improving access to these medicines. If you can produce an affordable drug that can be widely used by the patients, it's the benefit to the society, the benefit to the patient, in the end, benefit to us all.
To bring the insulin to the US market as well as the EU market is something that our US office is here to do.
The creation of the Gann Lee US affiliate was an extremely important step in the evolution of Gann Lee to becoming a global pharmaceutical company. Since that day, we've been building a team that could run the registration programs that would enable market access across the globe to all of Gann Lee's portfolio of therapeutics.
Our U.S. office was established in 2015. Since then, our staff has tripled in size. We moved to a larger facility with expanded capabilities, and we continue to grow a cohesive network here in the U.S.
Currently, we are working on 3 different products for diabetes. 2 of them are in phase 3 trials. For our phase 3 trials, we make sure that it is a global trial. We like to have our clinical trials conducted in the European Union and the United States.
One of the programs that I'm working on is Glargine, and this program has 2 large-scale phase 3 studies, one of which is type 2 diabetes study, which recruited 550 patients and achieved last patient out in April.
The mission of the company is quality first, innovation forever. So everything that we do touches upon quality and making sure that we are compliant with all regulations.
At Gann Lee, we go above and beyond to ensure that we use the highest quality standards that are available to ensure that our products are FDA compliant and compliant with the ethics committee standards as well.
The team at Gann Lee is ever growing, highly qualified, highly experienced. We're a very close-knit team.
Gann Lee is a great place to work because we have an awesome team dynamic, and in many ways we're like a family.
We have the type of culture where we all sit down and have lunch together. It doesn't matter what level we are. We share discussions and enjoy each other's conversations, and it's a really nice place to work.
Gann Lee is an amazing place to work, not just the highest quality standard products that we want to bring to the market, but also working together as a team to make sure that the entire process of clinical trials is followed accurately.
Everybody works so well together, and there's such a commitment and drive that so much gets done so quickly, much faster than I've seen in any other company.
It's always a great opportunity to work at a company that's growing rapidly, and in just a matter of years we'll be able to be providing products to the American market and the European market that are going to make a difference in patients' lives.
Diabetes rates are increasing rapidly in the developing world, while health systems there don't necessarily have the capacity to deal with the growing crisis. Strengthening diabetes services in countries like Guinea by working with local organizations. Let's take a look at the World Diabetes Foundation.
The World Diabetes Foundation has been in existence since 2002 to improve access to prevention and care for diabetes in the developing countries, and to be able to address the needs of the most vulnerable people with diabetes who are in greatest need for this kind of help. We have funded over 550 projects in 110 countries, of which almost 230 projects are active even now. And we work with a very small team. So we are a highly efficient organization from that perspective. The burden of diabetes in developing countries is much higher because of the increase in the socio-economic status of the population. There is a rapid urbanization which is taking place. So the level of activity is going down. The eating pattern of the food has changed. People are putting on a lot of weight. The health system was not geared towards making a diagnosis. You might be having people who had the disease but were not being diagnosed. There has been a lack of focus on some of the very simple things that are extremely harmful or dangerous for people with diabetes. For example, the diabetic foot. Then the other area that we have paid a lot of attention to is prevention of blindness because of diabetes. Women getting diabetes during pregnancy. Addressing the issue of children with type 1 diabetes. The other area that we have addressed is the link between diabetes and tuberculosis. If you want a sustainable program, you need to work with, in the developing world, it is the government and it is the Ministry of Health. Otherwise, as soon as your funding ends, your program ends. We fund projects based on the needs from the country. Where people apply, we transfer money in tranches based on clearly defined outcomes. And as a consequence of that, in several countries, we have been able to move the agenda of funding small grassroots initiatives, which have now transformed into large national programs. By our funding, we are leveraging existing health systems, being a catalyst for change.
In Guinea, we have about 130,000 people living with diabetes. Unfortunately, 7% to 10 do not know they had diabetes. So the situation is not so good, but it's improving.
Je connais beaucoup de diabétiques. J'ai des amis, j'ai des gens qui avaient le diabète il y a plus de 10 ans, mais que je ne connais pas cela. C'est des amis. Mais dès que j'ai dit maintenant que j'ai le diabète, ils sont aussi dénoncés. Je connais un peu les symptômes et je sais quelles sont les précautions à prendre. Le plus grand défi d'être diabétique, c'est de l'accepter et savoir vivre avec cette maladie-là.
Professor Nabi Belde is actually the first endocrinologist that came back from France into Guinea. He formed the Foundation for Diabetes and Non-Communicable Diseases. He had a first funding from the World Diabetes Foundation in 2008.
We managed to put in place the first service in Conakry. That was the starting point of collaboration with World Diabetes Foundation. We managed to put 10 clinics specialized on diabetes around the country, across the country, and after that we were able to collaborate to improve the quality and the access of care for children living with diabetes. In the current project, we are trying to improve prevention of complication and quality of care, and we are seeing an improvement on awareness in general population. Government are progressively taking care of diabetes and NCD.
Ce centre de santé, le service d'endocrinologie, diabétologie, disons, ça a beaucoup aidé, ça a décentralisé l'offre de soins pour les enfants diabétiques. Et en plus du suivi des enfants diabétiques, il y a les diabétiques de l'environnement qui viennent pour leur suivi des routines, qui étaient obligés auparavant d'aller jusqu'à l'hôpital national donc pour avoir leur suivi des routines.
This is a typical project for WDF where we start building capacity in the capital city and letting the capacity expand into the regions. Nabi Belde has shown that it is actually possible to build capacity in a country that has been hit by many different challenges, the Ebola crisis and a lot of political instability, and at the same time he has achieved a quite high level of diabetes services.
Tous les bilans que je fais ici, là, le cœur, les œufs, le sang, tout ça là, ça me coûte 320 000 francs. Pendant que si je fais ça, on a un dans les différents services, ophtalmo, cardio, diabéto, ça peut dépasser ça. S'il y a des examens, je peux dépenser jusqu'à 800 000, 700 000, tout au complet. Le coût est abordable. Et je fais tout sur place, pas de déplacement. Parce que ce que je fais là, Si on me dit de faire ça dans les différents services, je ne peux pas faire en un jour. Je me sens bien avec le service. Je n'ai pas de problème. En tout cas, les consultations, tout ce qui se passe ici, à mon niveau, il n'y a pas de problème. Ça me réconforte.
WDF helped us with the experience, with the knowledge. We got support at each step of the project, from the beginning to final evaluation. We were able to take advantage of a lot of experience WDF got from the other developing countries. We hope to continue improving the quality of care in diabetes center in my country.
Now to New York and Mount Sinai Health System, Icon School of Medicine, where physicians and scientists are working across a range of study areas, including beta cell regeneration and diabetes and pregnancy.
The Hilda and J. Lester Gabrelov Division of Endocrinology, Diabetes, and Bone Disease has a number of strengths. We're an outstanding research division in diabetes and endocrine disorders, and we're also one of the largest divisions of endocrinology and diabetes in the country because the Mount Sinai Health System is one of the largest health systems in the United States. As such, we deliver care to a huge number of patients in the New York area.
This isn't the first study of its kind overall, but it is the first study of its kind in the United States, as well as the first study that's ever been funded by the National Institute of Health. What it is looking at the use of artificial pancreas, otherwise known as closed-loop systems, in the management of patients with type 1 diabetes during pregnancy. This is a very unique opportunity and a very great potential clinical tool that we envision as great opportunity to provide care for patients in the future. What we know currently about artificial pancreas systems, or closed-loop technology, is that it provides for patients the ability to increase their time and blood sugar target range, reduce the risk of hypoglycemia, as well as improve their quality of life. What we do not know at this point, though, is the benefits of these systems for patients who are in the most challenging time in diabetes care, which is during pregnancy. There have been no studies looking at the US population, and additionally, there have been no systems specifically designed solely for the use or to work specifically under the scenario of pregnancy. What I can tell you is that not every week is the same. One week there may be certain insulin requirements, the next week glucose levels may be dropping precipitously, and then 3 or 4 weeks later insulin requirements will dramatically increase. We really require glucose management systems that can fully accommodate these hormonal changes that occur throughout pregnancy, requiring a much more aggressive change in glucose and insulin delivery requirements.
The reason that we're interested in beta cell regeneration is that everybody with diabetes has inadequate numbers of fully functional beta cells. So in the United States, that's 30 million people. Globally, it's 420 million people. Our interest is in trying to make the remaining beta cells in people with all kinds of diabetes replicate, expand, grow, and replace the lost function that they have. The function of beta cells is to make insulin. Everybody with diabetes needs more insulin, and they need it to be secreted in the right amounts at the right time. The big picture is that all 420 million people in the world with diabetes need more beta cells, and yet, despite all the drugs on the market for treating diabetes, none of them work to increase beta cell numbers or beta cell mass. So our goal is to create drugs that are able to make beta cells regenerate, replicate, expand, and replace the lost insulin secretion that happens in people with diabetes. In 2015, we discovered the first class of drugs that's able to make human beta cells regenerate. Just this past year, we found new classes of beta cell regenerative drugs that partner with the previously discovered classes of drugs, and so we can make beta cells regenerate even more quickly now.
There's a very fluid interchange between our basic science departments, our scientists who are sort of working on the interface, and then really taking it to the clinic and bringing insights from the clinic back to the lab to ask questions. And this is really exemplified by our research in diabetes, where we have Dr. Andrew Stewart's group working on ways to regenerate pancreatic beta cells. And this therapy, if it comes to fruition, will be applicable not only to patients with type 1 diabetes, but also to patients with type 2 diabetes. And then we have scientists like Dr. Carol Levy, who are taking very practical approaches with new technology to use the artificial pancreas to help our patients with type 1 diabetes.
What we care about most is the lives of our patients. So our basic scientists care deeply about coming up with new treatments for patients with diabetes. And our physicians that take care of patients with diabetes are motivated to come up with better treatments. And diabetes is a complex disease. So you have to take care of the whole person. You have to know about their lives and how diabetes is affecting their lives. You have to deal with the patient's family so they can help the patient with diabetes. That's what makes Mount Sinai special. We're like a family, and we care about the family of our patients and the patients themselves to improve their life.
Let's go to the Harold Hamm Diabetes Center now, where researchers are looking closely at how nutrition impacts the long-term health of young children.
The University of Oklahoma Health Science Center, Harold Hamm Diabetes Center, started back in 2008 from the former president of the University of Oklahoma and Harold Hamm, who got together with the legislature and felt the pressing need for a diabetes center.
The rates of obesity and type 2 diabetes in the country are increasing dramatically. Oklahoma particularly has problems with that as a consequence of the Native American population, where it's a particular issue.
The Harold Hamm Research Center provides funding to study the mechanisms of disease through basic science research, but also clinical and translational research, so that we can identify interventions that show the greatest promise for stemming the obesity epidemic.
One of the other things that the Hamm Foundation has allowed us to do is to give away the largest single prize for diabetes researchers in the world. And so it brings us together with international experts and brings new ideas into Oklahoma.
This is a great time to be involved in research in this area, because I think there's so much work to be done, and we need to be able to intervene to be able to make lives better.
One of the things I'm really excited about, having joined the Harold Hamm Diabetes Center, is the ability to recruit national experts in diabetes through the Hamm Center Endowment. We have a number of well-qualified people who are coming in to gear up to form a core group of metabolism experts here in Oklahoma. We've been given the opportunity to fund pilot grants, team science grants, equipment grants. All the kind of things that are really hard money to come by have been granted to us here, but it allows us to do many more things in the laboratory that we couldn't do otherwise.
With our team science initiatives, we've tried to connect our clinician researchers with some more of the basic research faculty within the Harold Hamm Diabetes Center. These unique partnerships have allowed us to take what we see in the clinic and in our patients and get back more to the mechanism right there at the bench with the help of the basic scientist.
Well, the Harold Hamm Center has helped in a number of different ways. They were integral in the development of our metabolic research center that exists in the OU Children's Physicians Building. This is a location where we are able to study body composition of babies and children to be able to determine percentage fat compositions. We can evaluate the character of their blood vessels in terms of how elastic they are, which is an issue with the development of high blood pressure that even begins as early as childhood. From a clinical standpoint, we are involved in a national study called the Today Study.
The Today Study, which is the treatment options for diabetes in adolescents and youth, has provided the only cohort of youth-onset diabetes that's ever been collected. And from this, we have seen that half of them fail therapy within the first 2 years of life. This is prompting us to further trials to see what we can do to preserve their beta cell function and prevent the complications and comorbidities of diabetes in this unique population.
In addition to in-depth cellular and human translational studies, we've been given the opportunity to develop many clinical programs here at the University of Oklahoma Health Science Center, whether it's a cooking class or a diabetes prevention class or a transition from teenagers to adults. All of that is part of the Harold Hamm Diabetes Center, and it really underlies what we're trying to do. If we can make a difference both in the community and in the laboratory, that will elevate our status nationally at the level where we need to be to really try and be at the forefront of conquering problems that are in diabetes and chronically here in Oklahoma.
As a society, we need to focus on improving nutritional practices across the lifespan. Studies have shown that diets of 18-month-olds are already high in sweets and low in fruits and vegetables, and so we need to focus on reversing that trend.
So the Nutrition Kitchen is awesome because it feeds into the need of people who have been diagnosed with diabetes but don't understand how their metabolism works. So if they can understand what foods they eat and how it impacts their body, they can make healthy choices and then live a better life.
In the maternal fetal medicine section, we're excited about the new direction of the Harold Hamm Diabetes Center, focusing more on the first 1,000 days.
I've spent a lot of time in my career understanding the impact of nutrition on development of metabolic systems in newborn babies. So that would be everything from the stem cell to fat cells, where they develop and how they develop, to the microbiome. The microbiome is where your nutrition and your gut interact, and understanding those interactions in that naive first 1,000 days of life will give us a window into how nutrition can impact the microbiome and therefore impact relative risk for type 1 diabetes as well as type 2.
Partnering with the Harold Hamm Diabetes Center, Neonatology and Pediatrics, we'll be able to address these problems from a research perspective in a more multidisciplinary way than we previously have been.
So I think in a year from now, if you talk to me, you're going to see a real growth in terms of what we're doing here in Oklahoma in the metabolic arena during this first 1,000 days. Really excited about that opportunity.
This year sees the release of a new documentary looking at the lives of people living with type 2 diabetes, narrated by actor Viola Davis and featuring the CEO of the American Diabetes Association, Tracy Brown. Let's take a look at the trailer.
More than 30 million American adults are living with diabetes, and 90 to 95% have type 2 diabetes.
When you have diabetes, you have to do what you have to do. I mean, it's not a disease that goes away. It's 365 days a year, 24 hours a day.
I woke up, I couldn't see. My head was pounding. My body felt like I was walking underwater. I didn't know what was going on.
It never passed through my mind that I'm going to have diabetes, even though I know that I have it in my genes because of my family history. I never know that I would be diagnosed with diabetes.
When they told me I was diabetic, he gave me a pamphlet. And that was it.
This isn't a problem, this is an epidemic.
There is a semblance of shame that is forced upon people with diabetes. I didn't choose to get diabetes.
If current trends continue, by 2030, the prevalence of diabetes in the United States will increase by 54%.
Why is it important to stand up for diabetes? Because nobody else is doing it.
My life passion now is to educate as many people as I can about diabetes.
We all need to sound the alarm. Sound the alarm and help awaken the rest of the world to the seriousness of this disease.
Life is not over. It's not over. This is not the end of your life.
Walk proudly. And you can manage it.
Right now, we're in the main lobby of Moscone North, and directly behind me is the bookstore. And this is where you can find the latest and greatest material on diabetes, the latest clinical advancements, and also there'll be a special book signing. And to tell us all about this is Abe Ogden. Thanks for joining us.
Absolutely.
Well, why don't you tell us first and foremost the titles we have in the bookstore, some of the exciting material.
Absolutely. So we have 6 new titles that will be debuting here at the bookstore. We have one on medications, which is a new title for us. It'll be updated every year. We've got a new title on pregnancy, the medical management of pregnancy. We have 2 new nutrition guides for patients who are living with diabetes. And then we have a new book on insulin, practical insulin. And then finally, we have our new title, Diabetes and Technology, which will be featured at the book signing on Sunday at 2 p.m.
Yeah, tell me about the book signing.
The author, Boris Drazden, will be here on site to sign the book. It'll happen at 2 p.m. here in the bookstore. So we encourage everybody to stop by.
Do you find a lot of people looking for certain titles or a certain key topic, or you go there and it's just kind of a thirst for knowledge?
There is an overall thirst for knowledge.
Yes.
That's a good way to put it, yeah. In general, many of our titles focus on practical tips for implementing the standards of care in a clinical setting, and those are the titles that tend to do best and are the most popular.
Okay, so for anyone interested in the book signing and also coming to get some new material, we're in the main lobby of Moscone North, and thank you very much.
Absolutely, thanks for having me.
Friday night saw the networking event that kicks off the social side of the ADA scientific sessions. This time a special guest taught attendees how best to cook for a healthy lifestyle as part of the No Diabetes by Heart campaign. People living with type 2 diabetes have a dramatically increased risk of heart disease and stroke. Yet through good nutrition and a healthy lifestyle, this can be managed. Healthy eating is a big part of No Diabetes by Heart, and special guest, Chef Ronaldo Linares, stopped by to teach people how.
Bring it in. Do not be shy. You're here anyway. I know you hear me. If you could hear me, come on down, guys. You're going to get a little education, a little fun.
My name is Ronaldo Linares, and I cook with modern techniques and ancestral flavors. I like to use the ancestral flavors of my cooking from the Cuban background, Colombian background, and Latin background, and infuse it into today's world and making the food diabetic friendly and heart friendly.
Smell it. Now it's starting to smell.
Today, for the 79 scientific sessions, we are doing this really cool cooking demonstration. We're doing 3 different recipes. Some are favorites per se. One is a spatchcock chicken, which is pretty much taking the backbone off the chicken, roasting it, cuts cooking time. We're taking the skin off, leaving out the saturated fats. Saturated fats are no bueno. We don't want them in our food. We want flavor. We want people today to get inspired to look at food a little bit different, to love the food, to start educating themselves and be excited about cooking. No Diabetes by Heart is a great website. We're gonna find a lot of information on recipes, things that you could do to prevent heart disease, cardiovascular disease, along with helping you with your type 2 diabetes, your type 1, and being pre-diabetic as well. What I'm doing is just kind of being a driver for it and helping people see it and see what they're doing. And it's huge. The American Diabetes Association, American Heart Association are teaming up and really attacking diabetes at the front. So it's kind of like the Marines of the health industry, so I love it. If you really go into the kitchen and start cooking and bring in the family and start eliminating the processed foods, no more sodas, no more chips, replace with fruits. It's all about the land. It's all about what nature, what God has given us and creating food out of that. We need to go back to that. We need to educate ourselves before we get way too far into unhealthy habits. Health is our wealth. I mean, without our health, we can't focus on our career. We can't focus on education. We can't focus on our family.
It's time to speak to delegates as minds kick into gear for another enlightening scientific sessions. Today we wanted to know what physicians and researchers can do to best impact the lives of people living with diabetes. What can we do to help improve the lives of those living with diabetes?
Well, I think that the most important thing is that people have access to information, that they should know how important it is to exercise and to eat correctly. So you don't have to treat diabetes, but you get to prevent instead. But if people are already with diabetes, there are ways of improving the life quality still by doing the same things as eating correct and exercising, and having access to information is the most important thing, I would say.
2 or 3 things: education, education, and education. Patients should know the target values or what are their targets of their blood sugar level, their blood pressure levels, their cholesterol levels, and their HbA1c level. They should know about it. And when the levels are high, they should be very much worried about, and they should go to some healthcare professional to get these levels.
We had to educate them about food problems, food care, about hypoglycemia, and they don't develop the complications. And those who are in the later stage of diabetes with tertiary complications, we have to make their life more comfortable and slow the progression of complications.
So I think the most important thing we can do to improve the lives of diabetics is to really let people with type 1 diabetes and type 2 diabetes know about the hidden complications of nerve degradation from high blood sugar. You know, you don't really realize it when you're eating a meal and your sugar goes up and it comes back down and your A1C is okay, but those blood sugar spikes can really lead to nerve damage down the road.
I think that for my job is most important to use all methods: education, group education, medications, all of classes. The rest is then the thing of the patients. Yeah.
I think it needs to be an individualised approach for all patients, so I don't think one size fits all. I think that's something that we really need to concentrate on and say, you know, what might work for one person may not for another. For example, like pumps might be great for one individual but not for another, so I think it just depends on the person and their needs and sort of just listening to what they want, really.
That's it for the second day here in San Francisco. We're getting to know the very latest in everything from beta cell function to continuous glucose management. But there's plenty more to come. Tomorrow we'll have the latest recommendations based on the new CGM data and look at whether SGLT2 inhibitors should be prescribed in people with type 1 diabetes. Until then, make sure to watch the show online in your hotel and right here in the Moscone. We'll see you tomorrow.